Well, I think people are kind of slowly hopping on, and so I want to welcome everybody to our February meeting. And Rachel Pets, I'm one of the co-chairs, and feel free to kind of um, pop in the chat, kind of who you are and where you're coming from. I see familiar faces and some, or names, and some that I haven't seen before. And so we just want to welcome everybody to coming to the meeting today. Um, so a few announcements, and our biggest announcement is that we completed our elections, and we're super excited and happy to announce our new co-chair and our new secretary. So Courtney Valentine is our new co-chair, Jamil Smith, our new secretary. Welcome, congratulations to you both. We're so happy that you're both here and joining us. And in a minute, I'm going to have you both kind of introduce yourselves and kind of say kind of where you're coming from and what you do, and so the group can get to know you all a little better. Few other announcements just to kind of make people aware. You've seen that the call for proposals are open for the conference in the fall. So that pertains to both kind of any presentations or posters people are considering putting together, but also the ELO. And so if people have ideas in terms of topics that maybe they want to see, or maybe you have an idea for a presentation and you want to see if others would like to join you, this certainly can be a place to do so. Feel free to put your information in the chat, and you can also kind of course, send an email out as well. But we want to put that on people's radar, and we also just wanted to get a sense from the group if anyone has any opinions about the ELO. So often the Peds SIG, we put on the extended learning opportunity that occurs at the beginning of the conference, and so we are open to potential topics, interests people may have. Feel free to jump in if you have them, or shoot at me an email if there's some interest or ideas.
Could you define ELO for anyone who may need to know what the acronym is?
Yeah, extended learning opportunity. So it's like a 3-hour typically-ish training that's done.
Yeah, they're often called pre-conference workshops.
Yes.
So, but we call them ELOs.
Great. Two other announcements. We kind of are keeping the mentorship piece going. If you're seeking any mentorship or you want to be a mentor, please reach out to myself. I'm happy to help navigate that and help you find somebody. If you want help on anything related to your practice, we're here to kind of help facilitate that. If there are any job announcements, also please place them into the chat and we will put them out in our minutes. So I think without further ado, let's go ahead and let our new leaders kind of introduce themselves. If you all remember for those of you who attended last month's meeting, we did what we called like a member spotlight. And really the goal was to kind of have our members talk a little bit more about themselves and how they're promoting pediatric integrated care in whatever position they have and things that they want to learn from the SIG. So we would like our new leaders, Courtney and Jamil, can talk a little bit about their backgrounds and experiences, and then you all can get to know them a little bit better. So Courtney, how about you go first?
Sure. Hi, everyone. I'm Courtney Valentine. I'm super excited to be part of the Peds SIG and the leadership this next year. So thank you so much. I'm going to talk a little bit for Member Spotlight, but I'm also going to do a little bit of overview about my organization and our training in a few minutes. So I am a licensed psychologist, also a school psychologist by training. I'm in Central Washington in a small town called Toppenish. And I work for Yakima Valley Farm Workers Clinic, which is a large FQHC. And we do the PCBH model, and I do the lifespan, but my passion is pediatrics, so I do a little bit of both. And what I'm most excited about for Peds SIG is ongoing connection, learning. I always feel like I'm kind of taking something new that I can apply to my work, but also, connecting to a group of people who are also passionate about the same thing. So thank you so much.
Awesome. Thanks, Courtney. We're happy to have you. Jamil.
Hi, everyone. I'm Jamil Smith. I am a licensed psychologist and trained school psychologist as well. And I am based in Detroit, Michigan. Did my training at Michigan State University in their school psych program. And I am on faculty at Wayne State University. We're in the heart of the city of Detroit. Right now, the only medical school in the city. And I'm in the Department of Pediatrics, and our practice plan where our faculty see their patients is called Wayne Pediatrics. And I am a part of that team. And we are implementing probably the best description is PCBH model. I see the physician's patients for more short/long-term psychotherapy, and then I have a clinical social worker that we work together to kind of implement things. She functions more as a BHC, even though that's not what it's called right now. And we work together to implement both prevention and intervention for our patients. And I am looking forward to Peds SIG, both serving to support the leadership and making connections and just improving our care.
Wonderful. Thank you, Jamil. Also really happy to have you join us in leadership. So today's topic is going to be on training models, training in pediatric integrated care. Myself and Courtney are actually going to kind of co-lead that this is how we do it today and talk about in our kind of respective positions, how we promote training. And I'm going to be speaking at the kind of graduate student level, and Courtney will be talking more about kind of intern postdoc level. And so, hoping that we can really facilitate a discussion too about training models that perhaps people have, or programs that people are a part of. How are they training? How are you training your students, your interns, your externs, your residents, et cetera? And to kick us off today, we're going to have Jonathan present an article, and he's going to talk a bit about, this is going to pertain to core competencies in psychology related to pediatric integrated care practice.
Yes. Well, hello, everyone. Hope you're all doing well. Share my screen. All right. So as Rachel said, today we're going to talk about competencies for the practice of pediatric integrated primary care, a continuum of training. I found this article and I thought it really kind of spoke to what we're going to be talking about today. And so to give you some background, the American Psychological Association had this initiative in 2012, and they came together and they identified these 6 competencies for practice in integrated primary care. Those included science, systems, professionalism, relationships, application, and education. However, those broad competencies utilized in integrated primary care may vary significantly based on the population served, such as pediatrics. So this article synthesized training competencies from clinical child psychology, pediatric psychology, and school psychology with those 6 competencies to prepare trainees for professional practice in pediatric integrated primary care. The article has this great table here. I'm just presenting it to you as an overview here. And I'm just going to touch real broadly on these competencies and how these may be applied to pediatric training in pediatric integrated primary care. So first, for science, this first competency cluster, it really discusses understanding science related to the biopsychosocial approach. It values a scientific foundation, application of evidence-based practice, and knowledge of epidemiology, public services, and health policy research. And also there's the research evaluation component, how to conduct research, apply appropriate research methods, work with the interdisciplinary team, knowledge of brief and valid measures, understanding how to use technology to assess patient outcomes, and disseminate research findings. The next competency cluster or group is systems. And the first part, leadership administration, understanding the mission and structure of a healthcare organization, promoting development and management across the clinical, operational, and financial domains, developing and supporting organizational change to optimize service delivery, knowledge of legal requirements and mandates, HIPAA mandated reporting, knowledge and application of organizational policies, healthcare business principles and procedures, and to pursue leadership roles and demonstrate effective communication and support training programs. Then this interdisciplinary systems part, understanding pediatric primary care and how it occurs within a larger healthcare community and social context, being aware of the overlap and separate roles of team members, and advocacy, recognizing the effect of healthcare policy on child and adolescent health, identifying healthcare needs on the pediatric population, advocating to inform policy, increase research, training, and practice within professional psychology. Next, professionalism, diversity, equity, and inclusion, acknowledging various worldviews and cultures, recognizing the relationship between sociocultural factors on health and illness on child and adolescents, and demonstrating appreciation and respect for diversity. Values and attitudes, reinforcing and strengthening one's professional identity as a pediatric psychologist, demonstrating adaptability and flexibility within a fast-paced, demanding pediatric culture. Ethics, identifying issues unique to pediatric practice and displaying knowledge of legal issues and policies involved within healthcare systems. Self-assessment or self-care, recognizing the importance of self-assessment and self-care as a behavioral health clinician and physician. Relationships, interprofessionalism, appreciating the interdisciplinary team approach to care, forming collaborative interprofessional relationships, actively assessing team dynamics, interpersonal skills, sensitivity and self-awareness when interacting with diverse individuals, respecting complex issues that may arise when working with children and families, building and sustaining relationships in integrated primary care, demonstrating concise, clear, and respectful communication to patients, staff, clinicians, setting appropriate boundaries, and assisting with potential conflicts between clinicians, staff, patients, and systems. Application, this was a big one. So practice management considers level of integration, resources available, time constraints, adapts to the pace of the integrated primary care setting, demonstrates ability to interview, assess, provide interventions simultaneously with other providers, knowledge of payment influences, maintaining patient confidentiality, and using technology to facilitate service delivery. Assessment, knowledge of child development, understanding risk factors, strengths, protective factors, use of evidence-based screening measures, the ability to identify patient needs and goals in an appointment, ability to utilize, administer, and interpret psychological assessment, address referral questions, and communicate assessment verbally and in documentation to appropriate stakeholders. Intervention, provide brief, problem-focused, evidence-based intervention appropriate for the pediatric setting. Consider the impact of developmental level and intervention, consider the biopsychosocial model, and understand ethical and legal issues regarding consent for treatment of youth. Consultation, concisely communicate case conceptualizations, conceptualize the needs of the child based on developmental and environmental demands, efficiently identify and respond to referral questions, understand the role and interaction of other service providers for care of coordination. And our last competency cluster, education. Teaching, so educating future psychologists and other health professionals, knowledge about these competencies and how they may be applied, aware of the changing nature of the field and how to adapt to meet training needs, able to assess the effectiveness of training, incorporating teaching of other health professions into training, and last, supervision, training stakeholders about psychological services, knowledge of ethical, legal, and contextual issues, aware of educational and practice needs of the trainee, providing trainees with instruction on supervision models for integrated primary care, knowledge of the role of culture within the supervisor-trainee relationship, and utilizing a range of supervision methods and adjusting them accordingly to meet the needs of the trainee. And yeah, there we go. I encourage you all to look at the article for more specifics. I just want to kind of present an overview of how these integrated primary care competencies could be applied to the pediatric population.
Thanks, Jonathan. That's a good foundation and a good overview. So many different competencies. And so maybe we'll be able to come back to that and thinking about how we assess for those competencies, perhaps in our trainees or even in ourselves. We're going to start this is how we do it. I'm going to go first in doing kind of the background presentation, and then I'll let Courtney, and Courtney will kind of jump in, and towards the end, I think we can save questions for the very end and do our facilitated discussion. So I'm going to give me a moment and I will share my screen here with everybody. So get this going. All right, so I am going to talk about training clinical psychology graduate students in pediatric integrated care. I'm going to talk about my personal experiences at the different organizations that I've been at, and I'm going to talk about it in 3 different areas as it pertains to kind of the traditional and interprofessional classroom setting, building practicum experiences, and research as well. So before I jump into what I've done, I want to just give a brief background on myself and kind of how I ended up where I'm at. I started did my doctoral training in clinical psychology at Western Michigan University, and that was in fact where I became acquainted with pediatric integrated care, and I became acquainted with it in my coursework, but really fell in love with it once I had an externship or external practicum working in a pediatrician's office. And so it really kind of changed my trajectory in terms of what I wanted to do with my degree. I sought out training experiences at internship and postdoc. I trained at Geisinger. So kind of further my experiences in pediatric integrated primary care. And at that point, when I was done with postdoc, I was interested in going the academic route for kind of several reasons, but always wanted to teach, mentor, things of that nature. I really wanted to enhance the training, graduate level training of integrated care, and also promote applied research within this area. So that landed me at Wichita State University and their clinical PhD program. I was there for 3 years. Then I transitioned to Fairleigh Dickinson University, where I'm at now, also in their clinical PhD program. So talking a bit about how I've kind of attempted to kind of do this type of training in different settings, right? And so one is in the traditional classroom, which is really kind of the courses that I teach as a faculty member, core faculty member in a clinical psychology PhD program. I have this expertise. And is there a way to just promote familiarity, almost in the same way that I had the experiences in graduate school too, and kind of different courses? And so does this kind of relate to readings and practicum courses, a lot of practicum courses where students are either kind of externally or in kind of the internal clinic talking about cases. And perhaps there's an opportunity to present kind of readings or PCBH books to students just to get their feet wet, to know that there's a different mode of practice out there. I teach ethics, and so currently, promoting case examples from my time when I was in pediatric primary care, that there's tons of ethical dilemmas that arise in terms of multiple relationships and confidentiality and things of that nature. I also taught a child clinical course, which is really just kind of interventions for children. And one of the first readings that I give to the students talks about dissemination of evidence-based practice and the need for systems of care, which again aligns really nicely this perspective of providing care and primary care, and talking to about innovations in service delivery. I have a lecture and readings based upon transdiagnostic approaches and modular therapy, and so nicely kind of blends into brief and focused interventions that can be applied in primary care. But these are examples that are small, right? Like if I'm teaching this course, how do I kind of bring my expertise? But want to maybe go beyond that ideally. And so are there ways that we can build more specific knowledge? So when I was at Wichita State, I actually created an elective course. It's primary care psychology. It was actually a 1 credit, 1 week course. It was over the summer, so it's not a semester length long course. But it's more of an introduction. It's more than just we had a reading, right? We have several readings. And I really focused on the PCBH model, which is really what I was trained in. But there was some skills practice as well. So getting students familiar with this model, practicing some of those competencies, skills, behaviors that we might expect in primary care. That's the traditional classroom, but I want to expand beyond that because, as you know, our training is so siloed, right? You're in a clinical psych doc program, you're just really taking classes with other clinical psych students and maybe some other doctoral students and other programs in the psych department, but you never really go outside of your program or your department. And so that's where the interprofessional classroom comes in. I've partnered with 2 faculty from social work at FDU, Doctors Zakia Clay and Andrea Cole. And we pulled together a training program that's really trying to promote this collaborative learning early in your graduate training. So we're inviting graduate students from health disciplines across the university. And we have this training series we're going to implement this semester, which is really exciting. And the focus of the training series are really just on interprofessional competencies. It's not primary care specific per se, but it's kind of this foundational knowledge and how do you work together on a healthcare team, or how to communicate, how do you define roles on a team. And so our goal is bringing them together to deliver some of this content, but also for them to learn from each other. While they're in their externship placements out in the community, seeing patients and being able to bring that together in the classroom, and going to culminate in a simulated patient experience at the end of the semester where they can learn to apply the skills that they've learned in real time with their colleagues, their peers. And we have many health professions on campus at FDU. So I'm clinical psychology. There's actually also social psychology, school psychology, social work, nursing, pharmacy, OT. So we're hoping we can bring in these different disciplines. And we did get grant funded for this pilot project that we want to assess our outcomes related to attitudes towards interprofessional practice, knowledge, skills learned, satisfaction with training, things like that. That's up and coming, kind of excited to pilot that and kind of see where it goes. But we know that the classroom isn't enough, and you really want to get students in the setting, right? A big goal of mine, wherever I've been, is how do I get a student in an integrated care setting? Ideally pediatrics, my focus, but I will take any integrated setting. And part of this is building relationships with community organizations, but it's also sustaining them. And there's always questions when you come in. Many programs already have kind of established relationships with different community agencies, but who's going to provide supervision? How do you pay for that potentially? Affiliation agreements. There's a lot that goes into placing students. And so one way that we've gone about this, same group of collaborators from social work, adding in a colleague, a school psychology faculty and nurse practitioner faculty, we obtained a HRSA grant that is going to give opportunities for students to be placed in these settings. And actually, the grant focuses generally on providing behavioral health services to youth in medically underserved communities. Some of these placements are FQHCs. We have a few integrated sites, and also the school system. So students get a stipend, supervisors get a stipend. They also get interprofessional training experiences, so kind of similar to the other grant project, but that they get to come together in the classroom as well. So it's another kind of great opportunity. Let's take them outside of the classroom. Let's give them those practical experiences, applied experiences as well. And finally, there's research. And so I oversee the Integrated Behavioral Health Lab at my university. So thinking about getting students involved in integrated care research. Another question is like partnering with community agencies in a way that it's mutually beneficial to kind of promote, answer questions that the community agency wants to have answered about integration, and also having students be involved in that process. It's a great learning opportunity. So this just kind of goes over as the background of my lab goals, values, and approach. And it can also give you some examples of projects that have been done previously. And there's kind of two ways that I go about this. And one is partnering with pediatric practices or FQHCs. And we've done some projects related to patient-provider acceptability of integrated care. I've partnered with the Pediatric, or the Research Consortium, Pediatric Integrated Primary Care Research Consortium. We did a series of we did a study related to parents' needs and preferences for services in pediatrics during the COVID-19 pandemic. I've also, this is probably more on the lab side of things, right? So we have this applied side of research and then the lab piece of how do we develop focused and efficient interventions in primary care? And so our research base isn't like super compelling for that. We have a research base about evidence-based practice and what we know works for children. But a lot of what we're doing in primary care is not, maybe you're seeing someone once or twice. And so it's an adaptation of our empirically supported treatments. And so thinking about when you're developing those, emphasizing change principles and processes, and can we evaluate them and see their effectiveness and see their kind of feasibility potentially in primary care settings. So I just want to highlight some student projects. I had a McNair scholar at Wichita State, and she actually presented this poster at CFHA a few years ago. Jonathan was also part of this project at the time, looking at college student perceptions of integrated care, because we were having student health services and student counseling services were coming together, really probably more in a more co-located fashion, and Jonathan could probably speak to that more than myself, but coming together. And what do students think about that? Would they like to seek services, mental health services there? And so we got some interesting kind of, perceptions from college students of what they thought about that. Another project, this was mixed methods. This was kind of an evaluation project with an FQHC and had some students involved, Kiki and Sarah. And finally, our very own Jonathan. Also, we did a study looking at providers' perceptions of integrated care. And again, this was that merger at Wichita State with student health services and student counseling services. So you'll notice some of these projects are not necessarily PED specific. So my lab operates broadly, and it kind of depends on research questions that providers or organizations have. Certainly, I do think that the PEDS aspect is a foundation of my work as well. But excited to kind of get students involved in this, applied research and thinking about different kind of ways to answer questions and partner with the community in doing this work. So I'll end there, and I hope we can come back to some of these questions a bit later in terms of thinking about promoting that interprofessional collaborative practice early on, and what needs to change to be able to do that. And I'm really interested too, for those of you who take externs or interns, postdocs, like what are those foundational knowledge and skills that they need to have to work in your setting. And then I would be interested in examples of training programs from the group. So I will stop there, and hopefully we can chat a little bit more. Feel free to jump in, Courtney. I think you're still muted.
1 second, let me get this going. Okay, so I'm going to talk a little bit about our training here at Yakima Valley Farm Workers Clinic. And we do a primary care behavioral health model. And so just to give a little overview, we are an FQHC in the Pacific Northwest. So we are in Washington State and in Oregon. And we are a fairly large organization with about 28 behavioral health consultants across our team. And we have a director, and then we have 3 leads, and I am the central region lead. And you can see that circle here is where I am in the Toppenish Clinic with Jada Hammond, who's on the call as well today, is one of our doctoral interns. And most of the training happens in this region, mostly because of kind of the way our organization is set up and the availability of me to be able to supervise in those ways. So a little overview of our organization. We see a large population of patients across the 2 states. Nearly 200,000 patients were seen in 2022, which is our last year of data that they share publicly. About 24% of our patients, though, are children. So a big bulk of children are served. We have some pediatric only clinics, and we also have clinics that are kind of family practice and a mix of pediatricians and other providers. A large portion of our population, like the name suggests, is our seasonal and migrant families. And we have a large portion of patients in many of our clinics who speak languages other than English. In my clinic, the high proportion of families come from Mexico, so speak Spanish. And then we see a lot of patients with Medicaid, Medicare, or uninsured. So this is our team. Toppenish, you're not familiar with Toppenish, is the city of murals. There's a lot of murals in our tiny little town, so this is one of them. And this is our team of BHCs across the 2 states. How we do training at Farm Workers is definitely meant to be a pipeline of training to recruit high quality employees and behavioral health consultants for the future. So a lot of training happens just as you're hired on as a behavioral health consultant in your role, and maybe you've never been in primary care before. So learning about how to do primary care. So we have psychologists on our team, we have social workers, LMFTs, and mental health counselors. So we have all different degrees representing our team staff. We also have 2 doctoral interns here in Toppenish with me. We have postdoctoral fellows. I actually started my organization as a postdoctoral fellow and stayed. That's a big way that we have recruited people. And for the coming year, our 2 interns are staying on for postdoc, and we have another postdoc currently in our Oregon clinics. We also have a social work associate who I'm supervising. We've had mental health counselor associate levels that are being under supervision. So we try to kind of find people who are great fits, who are from our community, that we can kind of help train and continue to build a workforce. And then in the past, we've done some practicum training for psychology in Oregon. And we have a new lead who's really trying to kind of build that up again with some of the universities like George Fox and Pacific in our Oregon clinics. Our PCBH model is based on the GATHER acronym, and so we really are seeing the lifespan, and this is what we really try to focus on in all of our training with all staff BHCs. So being a generalist, all ages, all presentations, very accessible, team-based, and high productivity. So we are trying to see a large number of patients each day for that real population health model. Try to do lots of educating, whether it's to our staff, to our BHCs, to our MAs, to our medical providers, to our administrators, to our patients and communities, and then routine pathways to get into care. We collaborated with the NPTC, which is the National Psychology Training Consortium, which is an APIC psychology internship. 3 years ago, this is our first year of interns in Toppenish, and I am so excited that we are part of this, this organization and continuing on. It's been a great way for us to expand our training. So we have 2 interns each year. We will find out in 2 weeks who we get for our next year. And then we are in a consortium in Cascades region, which is the Northwest. And so Amelia, also on the line, is from Central CHCW in Central Washington. We also have Health Point in Seattle. And so those are the 3 community organizations that are made up of that. And then we have each month our interns go to an in-person whole day didactic on different topics. And one of those months is on pediatrics, which Amelia led. And so we have different topics around primary care. And then we have the training in farm workers is really by me. So we do a lot of didactics. So once a month, our interns go to the Cascades region training. And then another time in the month, we do a farm workers based one. So these are topics that we focused on. One month, we went to our local elementary school and we had a school counselor talk to us about our work and how we collaborated. We've done months on women's health and perinatal and postpartum health. We've done months, this week is pediatrics and primary care. All of the topics that we do focus on the lifespan, but also how those things adapt to pediatrics. This is Toppenish. And why Toppenish for our region? It's our flagship clinic. It's where we started in 1978 with 2 doctors, and now we have over 22 providers in our clinic. We have a dedicated pediatrics department, family medicine, OBGYN, and internal medicine. We have a large group of integrated providers, community health worker, dental hygienist, registered dietitian, clinical pharmacist, SUD provider, BHCs. We have 4 of us in the clinic. We have a teaching clinic, all sorts of other amazing resources in the clinic, as well as outpatient counseling for kids and families, including psychiatry. So we have a lot in one building, and it is a very large building in our small town. And so a lot of our patients come here. And so it's been a great place to offer training and onboarding. This is our entryway. Again, the City of Murals, another one of our murals painted here. So what do we do that focuses more on pediatrics? Well, we run a school-based telehealth program for our Toppenish school districts. So we have iPads at each of our school districts. And 1 day a week, we run BHC visits just like we do in person, but we do it for the school so that we can reduce barriers to access to care. We are building some assessment pathways for autism spectrum disorder assessment in primary care, as well as enhancing our current assessments for child and adult ADHD. We have a REACH resident, which is a Seattle Children's Pediatric resident, and they come to Toppenish for 6 to 8 weeks at a time, a few times through the year. And it's a training pathway for the pediatric residents, and one goes to Kenya and one comes to Toppenish, and it's been happening for 10 plus years. And it's just a really amazing group of providers that come here with just such enthusiasm for the community. And we collaborate with almost all their projects that are around pediatrics. And it's a nice way for us to meet together with all the providers in the clinic and in the community. We also have a high-risk pediatric meeting that we attend monthly with our pediatricians, Indian Health Services, specialty care, to kind of collaborate and kind of figure out supports for high-risk patients, both emotionally and physically. We've done some presentations in the community, including a dietitian and with provider presentation on nutrition and behavioral considerations for neurodivergent children. And then since my background is in school psychology, they've done a ton of work with our school districts, and we've created a memorandum of understanding, which is a legal document that kind of allows us to use HIPAA to the highest degree so that we can communicate verbally and written without additional release of information for each family to help get kids into care faster and collaborate on assessments. And then we go to local community nights. We do once a year, we go to the school counseling meeting to start of the year to connect. We do parent nights, career panels, psychology presentations, kind of whatever we can do to connect with the schools. And this is our little training team. So we've got our 2 doctoral interns and one of our social work interns here for Halloween. So that is our training in Toppenish. So thank you.
Wonderful. And so let's open it up to questions that people might have, comments. Courtney and I mean, I'm kind of interested, and maybe we can start a larger conversation just about how to kind of approach training at different levels, right? And kind of thinking about it. And we have a great example, Courtney, with kind of internship and ways that there's onboarding and there's multiple didactics and and then also thinking, I think I'm always curious in terms of, as a faculty member in a clinical training program, kind of what, if you were, what kind of skills are needed, right? Like, what should we be really focusing on? So I'll open it up broadly to that, perhaps see if that kind of sparks something. What do we really need to be? What do we need to be training?
I was just going to comment that so it's interesting that you asked that question, because you're on the academic side, and I feel like I'm on the side where students are getting their experiences. So when I think about, I've hosted now 2 advanced PhD practicum students. So these are students in their last year before they're applying to internship. And and they happen to have come from school psych programs. And one of the things that we've talked about is, and it's so great that you're providing it in your program, is sort of this entree into what is, integrated care look like? What are the skills that are needed, and how do you practice some of those scenarios so that you're prepared? I think that training programs that offer a little bit more around integrated care really will set their students up to have an advantage to be able to come into an integrated setting as a trainee and then as a professional, having had that additional coursework, didactics, or whatever it looks like. So I'm really excited that that is something that you're offering. And I think training programs that do more of that will help us to be able to, have those students come in. And then I also want to say, as a practice, we're very small. And when I came on board, I was able to offer that additional training, those training opportunities that hadn't existed. And so my thinking was, well, where do I begin? How do I start small, right? Because I'm not at an APIC level. I don't have multiple colleagues with me to be able to offer, the breadth of training, and so I just started with what I thought was important. I created didactics that I thought would be useful, and sort of built the plane as we were flying. So I just want to encourage anyone who is sort of a small shop to, put your best foot forward, and because I think the work and training future professionals is so important.
Thank you. And I guess as you were speaking, it just, I don't know, like, just thinking about, again, kind of from my perspective, that a lot of students are going to they may end up in primary care, they don't know it, or they're going to be in medical settings. And I think that a lot of just speaking for kind of psych graduate training in particular, doesn't, I don't know if we are always really doing a great job of preparing for those settings. We can prepare kind of, practitioners in general, and we've got kind of core skills. And if you're part of a training program, there's the competencies and discipline specific knowledge and all these things that you need to be APA accredited. And, but yeah, I think often about, we don't always, and I don't know how to do it, get our students prepared for this, knowing that many of them will be there. They may not know it yet, but many of them might be working in these settings. And I know, just as I know APA actually they pulled together a curriculum for students related to integrated care. It's not pediatric specific, but there is kind of a curriculum through APA to kind of get at that, right? It's not required, obviously, in any of the programs, but knowing that this is needed. And just thinking about kind of what we're kind of lacking in terms of how to prepare to work with others in general, or just thinking about working in a health system, or even going back when I was thinking about Jonathan's presentation here of like competencies and practice management. And go again, some of this isn't going to come in graduate school because you don't have time and you've got to get all the foundational skills, but it just makes me think of ways, at least from clinical psychology, that we are behind in terms of preparing kind of some of our students and getting out there in those settings. And how do we change that on a larger level? I'm not quite sure. And I'd be curious of other professions too, if we have other, we're talking from clinical psychology, maybe school psychology, other professions. How do they train there at all, if at all?
I'm coming from a school psych background, and I think the thing that really helped me adapt well to primary care is that kind of systems approach and understanding that systems level goal and the levels of intervention, the universal, approach to work. And I think that helped me to, if you can understand a complicated hierarchy of a school, that kind of matches well to the hierarchy of a clinic and all the medical providers and how to adapt in those kinds of systems. The things I look for individuals kind of coming into primary care, doesn't matter the background, but just being able to want to collaborate, communicate across teams, be flexible, and kind of have that approach, especially for pediatrics. Can you think system wise? How does that work with, working with a school, thinking about a family system, a community system, because those are the pieces that when we think even adult work, you've got the person in front of you, but for kids so much we have to think about, what are all the other pieces that are impacting them, which is what I love, but I think it's a piece that not everyone, depending on your orientation, has had experience with.
Yeah, I think that's a great point. I think that's the probably why so many school psychologists end up in primary care in some form or another. Yeah, because we don't really get that in clinical psych training. Has anyone had, I guess, experiences? So this is moving beyond, I guess, maybe kind of specific programs, professions, but even the kind of interprofessional learning or training. And I think which naturally probably happens in some of your settings if you have, psych, you have interns and you have residents. But I'd be curious about those training programs as well and what people are doing or have experience with, or maybe in your training.
I can speak a little bit as a student who is going through it or is kind of in the process of going through it. I'm really lucky that my school, we had a lot of primary care related stuff. So like I kind of put in the chat, I got a couple of different grants that we had that our faculty got from like HRSA grants to integrate us into, we had a FQHC where I was studying too. So I worked in family medicine, and then we got one for pediatrics specifically, which I was so excited. That was my last year too. And I was like, thank God they finally got it before I left. So that was really exciting. We did a lot of like interprofessional stuff. So we actually had like a lab, it was called IPL, so interprofessional lab, where we had to like work with the residents and social workers, dietitians. I think there was even like dentistry, like, cause it's a big health college, Loma Linda. And so that was part of the grant. It was like written in, we had to go to the IPL. Which at first we were all kind of like, oh, why do we have to do this? But, having gone to it is actually really, really beneficial to see like how the different professions look at things, and also their understanding of like behavioral health and psychology and what they think we are able to do and help with, especially thinking about primary care, because that's kind of like a different way of doing behavioral health. So they're like, oh, well, the patient's not anxious or depressed, so like we don't need the psychologist. And I was like, yeah, but they have autism, or they have behavioral concerns, or and they didn't like think about those things. And so that was cool to be able to be like, I can help with that, I'm available. So I think I had really good training in that aspect, and my school was really good at like putting that out there curriculum wise and like experience wise. All of my practicums were like in primary care settings. So that was very helpful for me, I think.
That's wonderful to hear, Jada. It's affirming in some ways of some of the work that I'm trying to do with the grants. And what you are mentioning is exactly the kind of experience that we hope to foster, which is we get you together and then talk about how you might approach a case, and then hey, here's how behavioral health can be involved, and it doesn't have to be just because they didn't report anxiety or depression or whatever. Like, I'm here with health behaviors or adjustment or whatever, and so uh you know other professions being able to kind of, I know from a psych perspective, here's how we can kind of help, which is pretty cool to hear. And so yeah, so I think that kind of work early is exciting, and I'm kind of curious to see where it leads, but I'm also aware that a lot of that is based upon funding, right? Like, you're part of a grant and that gives you resources that can bring everyone together. But generally speaking, in graduate training, you're not going to, I'm housed in School of Psychology and Counseling. I have no overlap with any of these other profession, and the other programs. And so it just becomes difficult to even foster something like that outside of a grant opportunity. But that we won't give up. That doesn't mean it's not possible. And it actually makes me think that my social work colleagues are housed within the School of Health Sciences and Pharmacy. And I thought that was wonderful, and I'm jealous of them. Of course, I understand why I'm in School of Psychology and Counseling, and psychology has its own, but they get to be with nursing, or no, sorry, pharmacy, and PAs and others professions. And so the kind of structure of their school is different, that allows them that opportunity, which I thought was really cool. So anyway, parting shots or thoughts about kind of training experiences, ways that we can promote, grow at different levels, different professions.
I mean, Rachel.
Me too.
So we do a peer-led interprofessional educational series. We thought it was more convenient for engagement and other reasons to have our own practices be the teachers and learners, because we have a network of practices that are independently owned. So we support them, but everyone is its own entity and they like to be independent. So honoring that as well. But also because of the dissemination issues we have, I assume you all have them too. That is hard to, what someone does well is hard to spread across other settings. So this is the third year we are doing it, and it's going well. We don't have full attendance because it's a voluntary program, but we are always excited and it's helpful. My colleague Dan is here in attendance today. We presented this at the conference, and it's a highlight for us too. It keeps us alive and excited about the work. So we feel that it's also for us, it's a learning community for us. Yeah, that's how we do it.
Thanks for sharing. Yeah, it's exciting to hear about kind of what other people are doing. And so thank you all for coming, and we will see you in March. Bye.
Thank you, everyone.
Sounds good.
Can
Thank
you
you.
hang on, Rachel?